what are the salient features of shoulder dislocation and what are the things that we need to know about it. So, as you know, the shoulder is a ball and socket joint. It is made up of 3 joints: the glenohumeral, acromioclavicular, and sternoclavicular. It's very mobile, but it's also very unstable joint. It is stabilized by rotator cuff muscles, namely the supra-infraspinatus, teres minus, and the subscapularis. Okay. The main idea here is to understand that the head of the humerus is very large in comparison to the very small glenoid. Now, so what is a dislocation? Dislocation is basically defined as when there is a total loss of contact between the 2 surfaces forming a joint. So this is when the head of the humerus separates from the scapula at the glenohumeral joint. So scapula meaning the glenohumeral joint is separated. Okay, the glenoid and the humerus are separated from each other. Okay, now this is of various types. So the anterior dislocation is very common. So it is the most common type. By anterior dislocation, basically we mean is that the head of the humerus comes out anteriorly from the shoulder joint. Now, when it comes out anteriorly, it can go below the coracoid. In that place, it's called subcoracoid. It can go below the glenoid. It's called a subglenoid. And it can go below the clavicle. Then the shoulder dislocation is termed as subclavicular. In about 4% cases, it can go the back of the glenoid, where it is called as the posterior dislocation. Very rarely, it can go below, and it's called the inferior dislocation. Okay. So what are the risk factors which lead to shoulder dislocation? Age is one of the factors. Very young and very old can have shoulder dislocation. Can be congenital in some patients, where they can have inherent instability of the shoulder and can have multiple shoulder dislocations. But 95% are due to an activity or some kind of trauma, maybe a motor vehicle accident or a fall into the shoulder. Previous dislocation and trauma can weaken the muscles and tendons around that area and can cause instability of the shoulder and can predispose to further shoulder dislocations. So we need to protect the shoulder joint, build up the muscles and strengthen the muscles around it so that the shoulder dislocation doesn't happen, and do not take part in high-risk activities. Okay. History is very crucial. You need to really ask questions: how this happened, how many times has it happened, is it new or is it been happening from the birth, is there any family history? These are the kind of questions you should ask. Mechanism of injury is very important. So high velocity trauma versus just a simple fall can be can be helpful in differentiating whether there is some underlying pathology like weakness of muscles pre-existing, or it is just new thing that's happened. Position of arm at the time of injury is very important. So that would basically explain you the anterior and the posterior dislocation. So the position of the arm and when the force acts on the shoulder in that position is how you can determine whether the shoulder dislocation will result in anterior dislocation or a posterior dislocation of the humeral head. So in an anterior dislocation, the arm is abducted. Abducted means away from the body and externally rotated. Whereas in a posterior dislocation, the arm is adducted and internally rotated when the force happens. In inferior dislocation, the arm is fully abducted, so outside, and elbow is often flexed on or behind hand. Okay, so anterior arm is outside, abducted and externally rotated. Posterior arm is adducted towards the body and internally rotated when the force happens. And inferior when it's abducted and the elbow is flexed or is behind. Okay, so what are the clinical features? So you have a normal loss of contour of the shoulder. So if you ever have a look at someone's shoulders or your own shoulders in the mirror, you'll see that there are very nice rounded contours of the shoulder. The first thing that you notice in the people who have this dislocation of the shoulder, or you're suspecting a shoulder dislocation based upon the history that they give you, is you'll see that if it's on one side, the affected side will have loss of that rounded contour over the shoulder. We complain of shoulder pain, obviously. The range of movement is decreased in the joint. Obviously, there is no more joint left, so very decreased range of movements. You could possibly feel the humeral head. The apprehension test is positive, so if you try to dislocate the shoulder, the patient complains of severe pain, that's basically your apprehension test. So you see in the picture, all you need for diagnosis is an X-ray. So the X-ray here shows you that the shoulder is located outside the glenohumeral joint. So that's your glenoid there. Normally this humeral head here should be lying here. Okay, so you can see that's an anterior-inferior dislocation, although it's very difficult to say whether it's interior because you're just looking the front part of the X-ray. You need to look at front and the lateral X-ray, so the AP and the lateral X-ray. Treatment of shoulder dislocation is analgesia and muscle relaxant. You reduce the shoulder in the emergency department and as soon as possible with the proper neurological exam preoperatively and postoperatively, so pre-reduction and post-reduction. You immobilize for a few days and then start gentle range of motion. Physiotherapy and rehab is very important to strengthen the muscles. So if complex dislocation or recurrent dislocation, then you should consider surgery. Okay, now reduction can be by different methods. So basically you have to flex the arm to 90 degrees and externally rotate the humerus. However, there are certain contraindications where you do not attempt reduction. So these can be a subclavicular intrathoracic dislocation when you have a suspicion of major vessel damage. So just similar features as in a compartment syndrome. Then you have fractures around the shoulder, as you may further displace the fractures. If you try to relocate a dislocated shoulder, you may further displace a fracture. You may cause more harm than good. The prognosis is very, very good. About 80 to 90% of the younger patients, especially those in less than 20 years at the time of initial dislocation, they can have recurrence, but usually the prognosis is good. Of patients younger than 40 years, 26 to 48% develop dislocation, and dislocation is only in about 10% of patients over 40 years. So as the age increases, the rate of dislocation decreases, the recurrence rate of dislocation decreases. So minor trauma that results in a dislocation is associated with 86% recurrence rate. Okay, so if you look at this X-ray, the X-ray on the left is an anterior posterior X-ray of the shoulder, and the X-ray on the right is a lateral view of the same patient. So this is a 66-year-old male which came to us after a fall onto the right shoulder. So as you can see on the left-hand side here, this is the glenoid, and that's your head of the humerus. So ideally this head of the humerus should be lying in here. However, it's lying outside. So I'll show you this image. So that's how the head of the humerus should be. So that's the head of the humerus there. Okay, and you can see that it articulates with the glenoid very nicely there. But as in this case on the left hand side, if I zoom in there, you can see that the glenoid is separate and the head of the humerus is lying outside. So that's a dislocated shoulder. Okay, now you can see that it's come inferiorly. However, to identify whether it's gone anteriorly or posteriorly, you need to have a lateral view X-ray. So if you look at this lateral view X-ray, you can see that's the head of the humerus there. That's a glenoid cavity. Okay, so or a glenoid as we call it. So how do you know it's gone anteriorly posteriorly is you look at this thing here. So that's a coracoid and that's the acromion. Okay, so as a scapula comes in, it gives out this acromion process here posteriorly, and the coracoid goes anteriorly. You can see that head is going anteriorly towards the coracoid, and we also know it's anterior unless proved otherwise, because 95% cases are anterior. Okay, so if we have a look at the front and the AP and the lateral X-rays, you can see this AP view shows head dislocated, and then you look at that lateral view to see where the head is going anteriorly or posteriorly. Okay, now after reduction, this is how the X-rays look like. So the X-ray on the right is where the head is dislocated out of the shoulder joint, and the X-ray on the left here, this one, is where you can see the head is inside the glenoid cavity, or the glenohumeral joint is intact. Okay, now if you look at the lateral view for both preoperatively and postoperatively, you can see this one, that glenoid is separate and the head is lying separately outside the joint, whereas on the left hand side you can see the head is very well enlocated. Okay, so that's a brief overview of shoulder dislocation. What is a shoulder joint? How do you define a shoulder dislocation? The common aspects of shoulder dislocation, features, presentation, how do you diagnose, and how you treat.